Welcome back to the deep dive. Today, we're doing something a little different. We're going to turn off the casual interest mode, and we are entering the arena.
We certainly are.
I want you to close your eyes for a second. Imagine the fluorescent lights are buzzing, the air conditioning is humming just a little too loudly, and you're sitting on one of those uncomfortable wooden chairs.
I can picture it.
And across the table sits a senior examiner. They've got a strained face, a red pen, and a stack of mark sheets right in front of them.
That's a terrifying image, but it's the absolute reality for our listeners today. We are simulating a high-stakes postgraduate study session.
Exactly.
We're targeting the MD anesthesiology curriculum. I'm thinking specifically the level you'd expect at Gujarat University or, the European diploma, the FRCA. This is not about skimming the surface.
Yeah.
This is about survival.
Right. And to do that, we've pulled from the heavy hitters. I mean, we've got Miller's Anesthesia right here, Morgan and McLeod, the Oxford Handbook, and a stack of ICU protocols on the desk.
The core texts.
And our mission, our only mission, is to synthesize these thousands of pages into a coherent, exam-winning narrative. And the topic on the chopping block today, it's the bread and butter of our existence. It's oxygen.
Specifically, the alveolar arterial PO₂ difference, oxygen therapy, and then the big one, hyperbaric oxygen therapy.
Okay, so let me play devil's advocate for a second. Why this specific cluster? I mean, it seems basic, doesn't it? Everyone knows how to put on a nasal cannula. Why do examiners obsess over this so much?
Because it's deceptive. It looks simple on the surface, but it's the absolute cornerstone of perioperative safety. It tests your grasp of basic physiology, your mathematical application, and your clinical decision-making all at once. I'll tell you this, in a viva voce, if I hand you an ABG and you can't explain the A gradient, the exam is effectively over.
Wow.
In my mind, you're unsafe. If you can't differentiate between the patient who won't breathe and a patient who can't breathe, you simply cannot manage an ICU.
So we need to move way beyond just oxygen is good and get into the actual physics of gas exchange.
That's the leap.
Okay, so we're going to break this down into 4 massive chunks. The gradient, then oxygen therapy, then the physics of hyperbaric, and finally we'll tie it all together with clinical integration. Let's start with the exam framing.
Right, so if you get this as a long question, say a 10 or a 20 marker, it'll usually be framed as describe the oxygen cascade and factors affecting the A gradient. And you need to be ready to draw that cascade.
The whole waterfall diagram.
The whole thing. Now, if it's a short note, it might be something more focused, like oxygen toxicity or maybe indications for HBOT.
And the VIVA, the OSCE.
Well, the VIVA is almost always practical. I'll hand you a blood gas result. I'll literally point my finger at the PO₂ and say, this is 50 mmHg. And you need to be able to walk me through the math right there and then.
No hesitation?
None. In an OSCE, I might hand you a Venturi mask and say, explain the physics of these colored entrainment ports. You can't bluff this stuff. You need the equations cold.
All right, consider us warned. Let's dive straight into Part B. The alveolar arterial PO₂ difference. The A gradient. This is, as you said, absolutely essential.
It is.
So let's start with the absolute basics. Definition. If a student is asked, what is the A gradient? What is the exact sentence that needs to come out of their mouth?
Okay, the line to remember is, it is the difference between the partial pressure of oxygen in the alveoli, and you have to say denoted as big A, and the partial pressure of oxygen in the arterial blood denoted as little a.
So mathematically, PaO2 minus PO₂.
Simple as that. Big A minus little a.
But conceptually, what are we actually measuring? What does that number tell us?
You're measuring the efficiency of the lung as a gas exchange unit. That is the key phrase you're listening for. Efficiency of gas exchange. In a perfect ideal theoretical lung.
Which doesn't exist.
Which doesn't exist, of course. But in that perfect lung, there'd be no barrier to diffusion, and you'd have perfect VQ matching. The oxygen in the air sac would equilibrate perfectly with the oxygen in the blood.
Yeah.
And the gradient.
It'll be 0.
It would be 0.
But it's never 0, is it? Not even in a healthy 20-year-old athlete.
Correct. And that is a huge viva point. If you say it should be 0, you've already made a mistake. A small gradient always exists. And it's because of what we call physiological shunt.
Okay, explain that.
We have a couple of sources. First, the Thebesian veins that drain the myocardium itself. And second, the bronchial circulation that supplies the airways.
Right.
These two systems dump deoxygenated blood directly into the left side of the circulation. They go straight into the arterial side, completely bypassing the alveoli.
So it's a little bit of venous blood contaminating the arterial blood.
Exactly. We call it venous admixture. It just dilutes the final arterial oxygen concentration ever so slightly.
Got it. So to calculate this gradient, we need two numbers. The little a, the PO₂, we get that from sticking a needle in the radial artery. That's the easy part.
That's the measured value from the lab.
But we can't stick a needle in an alveolus, so we have to calculate the big A.
Which brings us to the alveolar gas equation, or the AGE. This is what I'd call exam gold. You cannot look at the ceiling and fumble for this. You must have this memorized, ready to go.
Okay, walk us through it slowly.
All right, the full equation is PaO2 equals FiO2.
Fraction of inspired oxygen.
Multiplied by the quantity, Pb minus pH2O. That's barometric pressure minus water vapor pressure. And then from that whole term, you subtract another term, PaO2 divided by R.
Okay, let's strip that down because there are 4 variables there that can trap people. First, Pb, barometric pressure.
At sea level, that's 760 millimeters of mercury. Now, if your exam happens to be in a high-altitude city, remember that number drops. But the standard assumption for most boards, unless told otherwise, is 760.
Okay. Second variable, pH2O, water vapor. Why do we subtract this? This is a step I see students forget all the time.
And it's a critical one. You see, when you inhale dry air, your upper airway works incredibly hard to warm and humidify it. By the time that air hits the carina, it is fully saturated at 37 degrees Celsius.
And that water vapor takes up space.
It takes up physical space, and more importantly, it exerts its own pressure. Specifically, it exerts a pressure of 47 millimeters mercury. It's pushing the other gases out of the way, in a sense. So the actual driving pressure of the dry gas you're breathing isn't 760, it's 760 minus 47.
Which is 713.
Exactly. So that's the number you're actually working with for the inspired gases.
That's such a crucial distinction. We aren't breathing 760 mmHg of usable gas. We're breathing 713 mmHg of gas plus this constant 47 of water vapor.
You got it. So then you multiply that 713 by the FiO2, so 0.21 for room air. That gives you roughly 150 millimeters of mercury of oxygen entering the alveolus.
But the alveolus isn't empty waiting for that oxygen. It's full of exhaust gas.
That's a great way to put it. Carbon dioxide is constantly pouring out of the blood into the alveolus. It's taking up space, exerting its own pressure, and that's the second half of the equation. You have to subtract PaO2 divided by R.
R being the respiratory quotient.
Yes, the ratio of CO2 produced to oxygen consumed. On a normal mixed diet, we assume it's 0.8. And a little mathematical trick for the exam, dividing by 0.8 is the same as multiplying by 1.25. It's often faster to do in your head.
So let's make this practical. For the listeners driving to the hospital right now, what is the back of the napkin formula they can use in a real clinical scenario on room air?
Okay, the simplified clinical formula one you should have ready to go is 150 minus 1.25 times PaCO2.
That's it.
That's it. It's fast, it's effective, and it beautifully highlights the relationship. If your patient hypoventilates and their CO2 goes up, your alveolar oxygen must come down. They are inversely related.
I like that. 150 minus 1.25 times CO2. Simple. Okay, so we've crunched the numbers. We've got our PO2, we've got our PO2, we subtract them, and we have a value for the gradient. What's normal? You said it's not 0.
Correct. In a young, healthy adult breathing room air, normal is somewhere between 5 to 15 millimeters of mercury. But, and this is the bit that separates a junior resident from a senior registrar, you absolutely must adjust for age.
Why? What happens as we get older? Does the membrane get thicker or something?
Not necessarily thicker, no. It's more about lung mechanics. As we age, the lung's elastic recoil decreases. This causes a phenomenon where the closing capacity starts to increase.
Closing capacity. Remind us.
It's the lung volume at which the small airways in the dependent parts of the lung, the bases when you're upright, start to close off during expiration.
Okay.
In an older person, this closing capacity can actually become larger than their functional residual capacity, their FRC.
So what does that mean in plain English?
It means that even during normal, quiet tidal breathing, some of their small airways at the lung bases are collapsing and reopening with every single breath.
So essentially, our grandparents have mild rolling atelectasis as a baseline state.
In a way, yes. You could frame it like that. They have these little areas of low VQ ratios at baseline, and that creates a larger physiological shunt than in a young person.
Is there a formula we can use to defend this in an exam so we don't just sound like we're making it up?
Absolutely. There are several. A more complex one from ICU protocols suggests the gradient equals 2.5 plus 0.21 times age in years.
A bit clunky for mental math.
It is. A much easier one to use at the bedside or in Aviva is simply age divided by 4 plus 4.
Let's test that. Take a 20-year-old.
Okay, 20 divided by 4 is 5, plus 4 is 9. A gradient of 9 mmHg, perfectly normal.
Now take an 80-year-old.
80 divided by 4 is 20, plus 4 is 24. A gradient of 24 mmHg can be perfectly normal for an 80-year-old.
That's a massive difference. So if I see a gradient of 20 in a 20-year-old, I'm getting really worried.
You should be.
But if I see that same gradient of 20 in an 80-year-old, I should be, well, relatively relaxed.
Exactly. And that's a key point of clinical maturity. If you hold the elderly to the physiological standards of the young, you will overdiagnose, overinvestigate, and overtreat.
There's one more factor that messes with our definition of normal, isn't there? And that's the FiO2 itself.
Yes, correct. The gradient is not linear. As you increase the inspired oxygen, the gradient naturally widens, even in healthy lungs.
Why does that happen?
The exact mechanisms are debated, but it's thought to be due to things like loss of hypoxic pulmonary vasoconstriction in areas of low VQ or creating microatelectasis. But the clinical takeaway is what matters.
Which is?
On 100% oxygen, a gradient of up to 100 or even 150 millimeters of mercury can be considered acceptable. So you can't just apply the room air rules. If you're pre-oxygenating a healthy patient and their gradient is 80, you do not panic.
That's a really important practical point. Okay, let's move into the pathology. We calculate the gradient, we correct for age, and it's still high. It's clearly widened. What is our differential diagnosis?
A widened gradient means intrinsic lung disease. The gas exchange unit itself is broken, and you should think in 3 main buckets: VQ mismatch, shunt, and diffusion defect.
VQ mismatch is the most common, right?
By far. This is the bread and butter of respiratory medicine. This is where you have both ventilation and perfusion, but they just aren't matched up very well.
Give us some examples.
Think of COPD, asthma, a small pulmonary embolus, or mild atelectasis. You've got blood flowing to parts of the lung that are just not getting enough air.
Okay, and shunt, how is that different?
True shunt is the absolute extreme of mismatch. It's where VQ equals 0. Blood is flowing past alveoli that have no ventilation whatsoever. It's completely bypassing any chance of gas exchange.
So that would be something like?
A completely collapsed lung unit, severe consolidation like in a bad pneumonia or ARDS, or an anatomical issue like an intracardiac right-to-left shunt.
Now, differentiating VQ mismatch from shunt is a classic exam trap. How do we distinguish them clinically at the bedside?
The key, the absolute key, is the response to supplemental oxygen.
Okay.
In VQ mismatch, those poorly ventilated alveoli are still getting some air. So if you crank up the FiO2, you raise the driving pressure of oxygen into those sick units, and the PO2 shoots up. It responds really well to oxygen.
And
shunt does not correct significantly with 100% oxygen. This is a critical VIVA distinction. It makes perfect sense if you think about it. No matter how much oxygen you shove into the open alveoli, if a big portion of your blood isn't even going past them, it won't pick up that oxygen.
So if the examiner asks, does oxygen fix the gradient? The answer is?
The answer is, it depends on the underlying pathology. That's the safe, intelligent answer.
Got it. And the third cause, the diffusion defect.
This is less common, but important to know. This is a physical thickening of that alveolar capillary membrane. Think interstitial lung disease, pulmonary fibrosis. It creates a physical barrier that slows down diffusion.
And how do those patients present?
Often, they have reasonable oxygenation at rest because the blood has enough time to transit the capillary and equilibrate, but they desaturate dramatically with even minimal exercise because the blood transit time becomes too fast for diffusion to keep up across that thickened membrane.
Okay, now for the really tricky scenario. The patient is hypoxemic, they're blue, their SATs are low, but you do the math, and the A gradient is completely normal for their age. What is happening?
This is what I call the hypoventilation trap, and it's a crucial one to understand. If the gradient is normal, it tells you the lungs are working fine. The transfer of gas from alveolus to blood is efficient.
So the lung tissue is innocent.
The lung tissue is innocent. So why is the arterial oxygen low? It must be because the alveolar oxygen is low to begin with.
And that brings us right back to the alveolar gas equation.
Precisely. If your PaO2 drops, your PO2 has to drop along with it. This happens in 2 main scenarios. Scenario 1, alveolar hypoventilation.
Ding, ding.
You just stop breathing enough. Think of an opioid overdose or residual neuromuscular blockade after a case. Your respiratory rate drops, your PO2 rises, and as that CO2 rises, it physically displaces oxygen in the alveolus. The gradient is preserved, but you're profoundly hypoxic.
Okay, and scenario 2.
Low inspired oxygen tension. This is much rarer. You're either at high altitude or, more terrifyingly, someone has connected the wrong gas pipeline to the wall. The air you're breathing simply doesn't have enough oxygen in it.
So to summarize clinically, the A gradient is really our first-line detective tool.
It's the diagnostic flowchart in your head. Is the patient hypoxemic? Yes. Okay, calculate the gradient. Is it normal? If yes, think about the pump hypoventilation or the environment. Is the gradient widened? If yes, then you know it's a problem with the lung tissue itself. Shunt, VQ mismatch, or diffusion.
That distinction seems critical for what you do next.
It's everything. It's the difference between giving naloxone and starting recruitment maneuvers.
Right. Let's shift gears now into Part C, oxygen therapy. We're anesthetists. Oxygen is our favorite drug. But do we really treat it like a drug?
We must. And in the exam, you have to define it as such. Don't just say giving oxygen. The correct phrasing is, oxygen therapy is the administration of oxygen at concentrations greater than ambient air to treat or prevent hypoxemia.
And what are the classic indications?
Well, documented hypoxemia is the obvious one. We usually use a threshold of a PO₂ less than 60 mmHg or saturations less than 90% on room air.
But we use it in other situations too, right?
Oh, absolutely. In acute trauma, shock, sepsis, any state where we're worried about tissue oxygen delivery or DO2, we're trying to maximize the amount of oxygen carried in the blood. And very specifically for us in the post-anesthesia period, to prevent diffusion hypoxia after using nitrous oxide.
Let's talk about targets. Are we always aiming for 100% SATs for every single patient?
Absolutely not. And saying that in an exam will fail you. Hyperoxia is dangerous. The modern approach is to have a target range. Generally, for most patients, we aim for an SpO2 of 94 to 98%.
And what about the exceptions?
The big exception is our chronic CO2 retainers, our severe COPD patients. For them, we aim for a lower target, usually 88 to 92%, to avoid worsening their hypercapnia. You must mention this specific population.
Let's talk about how we deliver it. The exam syllabus splits these into variable performance and fixed performance devices. This terminology feels like exam core material.
It is. You need to use these terms. Variable performance simply means that the FiO2 the patient actually receives varies based on their own breathing pattern.
So that's our nasal prongs and symbol face masks.
Exactly. You can set the flow meter at, say, 4 liters per minute. But if the patient gets breathless and takes a huge deep breath, they'll entrain a massive amount of room air around the mask, diluting the oxygen. So their effective FiO2 drops.
And if they take tiny, shallow breaths?
Then they entrain less room air, and the FiO2 they receive rises. The point is you can't be sure exactly what concentration they're getting breath to breath.
Okay, so what's a fixed performance device?
This is a device that is engineered to deliver a precise FiO2 regardless of the patient's respiratory effort. The classic example that everyone needs to know is the Venturi mask.
How does the Venturi work? This sounds like a perfect OSCE station.
It is. It relies on a physics principle called the Bernoulli principle. Oxygen is forced through a very narrow jet. This high velocity creates a zone of low pressure.
Like an airplane wing.
Exactly like that. This pressure drop actively sucks in, or entrains, a very specific amount of room air through carefully sized side ports. The mask comes with different colored adapters, and each one has a different sized jet and different sized ports.
So you get a precise mix.
You get a precise mix, and crucially, the total flow of gas, the oxygen plus the entrained air, is very high. It's usually higher than the patient's own peak inspiratory flow, which means they don't suck in any extra room air. They only breathe the mix you've created.
And what about high-flow nasal cannula, or HFNC? That's everywhere in our ICUs now. Where does that fit?
HFNC is a bit of a hybrid, but at high flows, it acts like a fixed performance device. It delivers warmed, humidified oxygen at flow rates up to 60 or 70 liters per minute.
Which is much more than anyone can breathe in.
Right, so it completely flushes out the anatomical dead space in the pharynx with pure, oxygen-rich gas. It provides very reliable FiO2, and as a bonus, it generates a little bit of P-positive and expiratory pressure, which can help recruit alveoli.
Now for the very high-yield section, complications. We said oxygen is a drug, and all drugs have side effects. It isn't harmless.
Far from it. In an exam, you should be ready to discuss 3 main mechanisms of harm. First, absorption atelectasis.
The nitrogen splint.
Exactly. Room air is about 79% nitrogen. And nitrogen is inert. It's not really absorbed into the blood, so it stays in the alveoli and acts as a sort of splint, keeping them open.
And when we give 100% oxygen,
we wash out all that nitrogen. Now, the alveolus is filled with pure oxygen, which is very rapidly absorbed into the bloodstream. If there's even a slight obstruction downstream, the alveolus can just collapse like a deflating balloon.
Yeah.
This is a major cause of post-op atelectasis and shunt.
Okay, complication number 2, CO2 retention in COPD patients.
Right. The old dogma, the thing everyone used to say, was that you were knocking out their hypoxic drive.
And that's not the full story.
It plays a very minor role. The 2 much bigger culprits are, 1, altering VQ matching. You're releasing hypoxic vasoconstriction in poorly ventilated areas, sending more blood to bad lung units. And 2, the Haldane effect.
Explain the Haldane effect.
In simple terms, oxygenated hemoglobin is more acidic and holds onto CO2 less tightly. So when you load up the hemoglobin with oxygen, it's forced to dump CO2 into the plasma and blood, raising the PaCO2.
And the third major complication?
Direct tissue toxicity. This is damage from reactive oxygen species, or ROS, free radicals. This is the Lorraine-Smith effect, which describes pulmonary toxicity.
What does that look like?
It starts as tracheobronchitis, but with prolonged exposure to high FiO2, or type greater than 0.6 for more than 24 to 48 hours, it can lead to diffuse alveolar damage that looks identical to ARDS. Then there's CNS toxicity, the Paul Bird effect, which causes seizures, but that's really more of an issue in the hyperbaric world.
Well, speaking of hyperbaric, let's move right into Part D, hyperbaric oxygen therapy, or HBOT. This topic tends to scare students because it involves physics we don't use every day.
It shouldn't be scary. It's really just a direct application of the basic gas laws you learned in first year. The definition is key. HBOT is breathing 100% oxygen at pressures greater than 1 atmosphere absolute, or ATA. Typically, we use pressures of 2 to 3 ATA.
What's the core physical principle at play here?
It all comes down to Henry's law. You must name this law in your answer. Henry's law states that the amount of a gas that dissolves in a liquid is directly proportional to the partial pressure of that gas above the liquid.
So more pressure, more gas dissolves.
Exactly. Normally, under standard conditions, hemoglobin carries almost all of our oxygen. The amount physically dissolved in plasma is tiny, almost negligible.
But in the chamber?
In the chamber at 3 ATA, the partial pressure of oxygen is so high that the amount of oxygen dissolved directly into the plasma increases massively. It can go up to about 6 volume%.
And to put that in perspective,
that enough dissolved oxygen to meet the body's entire resting metabolic needs, even if you had 0 functional hemoglobin.
That is a staggering fact.
Yeah.
So in that state, we are essentially bypassing the need for red blood cells to deliver oxygen.
In a sense, yes. And this has huge implications. It means oxygen can diffuse much, much deeper into tissues. The diffusion distance is massively increased, which is why it's so useful for things like crush injuries, compromised skin flaps, and areas with severe edema and ischemia.
Okay, so let's get into the indications. This is a classic exam question. What is the accepted list we should be quoting?
You're right to say accepted list. You don't want to list everything you read on some wellness blog.
Yeah.
Stick to the hard, evidence-based indications. Number 1 is decompression sickness.
The bends.
The bends. HBOT physically compresses the nitrogen bubbles, according to Boyle's law, and the high oxygen gradient helps wash the nitrogen out.
What's next?
Air or gas embolism. Same principle. You're shrinking the bubbles. Then, a huge one for us in emergency medicine, carbon monoxide poisoning.
Why is it so good for CO poisoning?
Because it dramatically reduces the half-life of carboxyhemoglobin. On room air, it's about 4 to 5 hours. On 100% oxygen via a non-rebreather, it's about 90 minutes. But in a hyperbaric chamber at 3 ATA, it's only about 20 to 25 minutes.
Wow, that's a massive difference.
It is. A few others to know are necrotizing soft tissue infections, particularly gas gangrene caused by Clostridia.
Because it's bactericidal to anaerobes.
Right. And things like osteoradionecrosis, where it helps promote new blood vessel growth, or angiogenesis.
Okay, and what about the complications? We mentioned the Paul Bird and Lorraine-Smith effects?
Yes. Oxygen seizures, the Paul Bird effect, are a very real risk at these high partial pressures. But the most common issue is barotrauma.
Ears and sinuses.
Ears and sinuses are the most common middle ear barotrauma. But the most dangerous one is pneumothorax. In fact, an untreated pneumothorax is the only absolute contraindication to HBOT.
Why is that?
Think about it. You take a patient with an undrained pneumothorax, you put them in the chamber and pressurize them. The air in their pleural space gets compressed. Then, at the end of the treatment, you decompress the chamber. That trapped air will rapidly expand according to Boyle's law.
And cause a tension pneumothorax.
And kill the patient. You must put in a chest drain before they go anywhere near the chamber.
A vital safety point. Okay, let's move to Part E and start tying this all together. Anesthetic and ICU correlation. How do we apply all this theory to our daily work in the operating theater?
Well, the AA gradient is critical even before the patient gets to the OT.
Yeah.
It's used in preoperative assessment, especially for thoracic surgery. If a patient for a lung resection has a wide gradient at rest on room air,
they're not going to tolerate having one lung collapse.
Exactly. They have very little pulmonary reserve. Intraoperatively, we have to remember that we cause hypoxemia. We are the problem. General anesthesia itself reduces FRC. The supine position allows the abdominal contents to push the diaphragm up, and then our muscle relaxants remove the muscular tone that keeps the chest wall open. We are actively creating compression atelectasis in the dependent lung zones.
So the shunt gets worse.
The shunt gets worse, and the A gradient widens even in young, healthy patients. This is an expected physiological consequence of anesthesia.
Which is why we use interventions like PEEP, right?
Exactly. We use PEEP to try and counteract that collapse, to prop those dependent alveoli open and improve VQ matching.
Now, in the ICU, we often move beyond just the A gradient to other more practical indices. We talk about the PF ratio all the time.
The PF ratio, which is just the PA2 divided by the FiO2, has become the standard for classifying the severity of ARDS under the Berlin definition. It's simple, it's quick to calculate, and it's easy to trend over time.
Remind us of the Berlin criteria numbers.
A PF ratio between 200 and 300 is mild ARDS.
Yeah.
Between 100 and 200 is moderate. And less than 100 is severe ARDS.
And for the really sick patients, or for our pediatric cases, we sometimes use something else.
We do. We use the oxygenation index, or OI. This is a more complex index because it also incorporates the mean airway pressure, the MAP, from the ventilator.
And the formula for that?
The formula is MAP times FiO2 times 100, all divided by the PO2. A high OI indicates very stiff lungs and very poor oxygenation, despite high ventilator pressures. It's often used as a trigger for considering more advanced therapies like ECMO.
And then there's the gold standard, which we don't use much clinically, but need to understand conceptually. The shunt equation, QSQ.
Right. This is the true gold standard for quantifying venous admixture. The formula is a bit of a mouthful. CCO2 minus CaO2 divided by CCO2 minus CVO2.
The C's being oxygen content, not pressure.
Critically important distinction. This equation uses oxygen content, which takes into account hemoglobin and saturation. It compares the oxygen content in an ideal pulmonary capillary, CCO2, to what's actually in the artery, CaO2, and what's returning in the venous blood, CVO2.
Why don't we use it every day?
Because to get the CCO2 and the CVO2, you need a mixed venous blood sample from the tip of a pulmonary artery catheter, which we just don't place very often anymore. But conceptually, it's the most accurate way to tell you exactly what percentage of the cardiac output is bypassing the lungs.
All right, we are in the home stretch now. Part F, exam integration. Let's talk about the VIVA traps. What are the common landmines waiting for a nervous candidate?
Trap number one, without a doubt, is the alveolar gas equation calculation. The student remembers the formula, but in their panic, they forget to subtract the water vapor pressure. They use 760 instead of 713.
And the whole calculation is wrong from the start.
It's immediately wrong, and the examiner will stop you right there and know you don't have the fundamentals down.
Okay, trap number two.
It's the question we discussed earlier. Does oxygen fix the gradient? The weak candidate says yes. The strong candidate says it depends. They then differentiate the excellent response seen in VQ mismatch from the minimal response seen in a true shunt.
And what about terminology traps?
The big one is hypoxemia versus hypoxia. They're not the same thing. You must be precise. Hypoxemia is low partial pressure of oxygen in the blood. Hypoxia is low or inadequate oxygenation at the tissue level.
Can you have one without the other?
Absolutely. In cyanide poisoning, you can have a normal PO2, no hypoxemia, but your tissues can't use the oxygen, so you have profound tissue hypoxia. Conversely, in severe anemia, your PO2 might be fine, but if you don't have enough hemoglobin to carry it, your tissues will be hypoxic. Be precise with your words.
In the higher level textbooks, they talk about the iso-shunt diagram. Is that something worth mentioning in an exam?
Mentioning it proves you've read beyond the basic handbook. It proves you've opened Miller. It's a graph that plots PO2 on the gourd axis against FiO2 on the x-axis. It has a series of curves, each representing a different shunt fraction, a 10% shunt, 20% shunt, and so on.
And what does it show?
It visually demonstrates that as the shunt fraction gets higher, the curves become flatter. It shows that with, say, a 30% or 40% shunt, increasing the FiO2 from 0.5 to 1.0 barely moves the PO2 at all. It's the graphical proof of why pure oxygen doesn't fix a large shunt.
That's a great visual. Okay, before we wrap this up, let's summarize. Give us the elevator pitch for the exam. If the listener takes away only 4 key things from this entire deep dive, what should they be?
Okay, 4 things. Number 1, oxygen is a drug. You must prescribe it with a target saturation in mind and always respect its toxicity.
Number 2.
The A gradient is your primary detective tool. It distinguishes won't breathe which is hypoventilation, a normal gradient problem from can't breathe, which is intrinsic lung pathology, a widened gradient problem.
Number 3.
The alveolar gas equation is your best friend. You must memorize it. The simplified version on room air is 150 minus 1.25 times the PO₂.
And finally, number 4.
HBOT is not about hemoglobin. It's about pressure and dissolved oxygen. It uses Henry's law to bypass the normal oxygen transport system.
Fantastic. This has been a true deep dive. We've gone from the alveolar membrane all the way to the hyperbaric chamber.
It's incredibly dense material, I know, but mastering the principles of oxygen transport is what separates a technician from a true consultant anesthesiologist.
Yeah.
You absolutely need to own these numbers and these concepts.
All right, one final provocative thought for our listeners to mull over as they head into their exams. We established that the A gradient naturally and predictably increases with age. So my question is this. Do our standard criteria for hypoxemia need to be age-adjusted more aggressively in the elderly? Are we constantly overtreating 80-year-olds by applying a PO₂ target that was derived from studies on 20-year-old lungs?
That is a very good question. Something to think about.
Indeed. Keep your gradients low and your saturations high. And good luck with the exams.